Hello and welcome, dear students. And today we are going to take up a topic called gestational trophoblastic disease. And why I'm calling it gestational trophoblastic disease and not neoplasia is because my Viva or the case doesn't restrict itself to just neoplasia. I'm going to be talking about the benign forms as well, and then we'll go to the malignant form, which is choriocarcinoma. And see, whenever we discuss a case, we discuss it in toto. That means the way it can be asked in exams. So we're going to be discussing only those questions which are expected of you at this point in time in your career, and the pet favorite questions of examiners, and that too in the light of the latest FIGO update 2021. By now, anytime soon to 2022 would also be updated. But as of now, it's going to be the latest one, 2021 FIGO update, the classification, the staging, the risk factors, and the follow-up. So without wasting any time, let's begin with the case presentation. My patient, Mrs. X, 23-year-old patient coming from so-and-so place, resident of so-and-so place, is a housewife by profession belonging to a lower middle class. The history is that patient was the presenting complaints are that of bleeding per vaginum since the past 6 months, for which she's been referred from another institute. Now, patient was apparently normal 6 months ago when she had a spontaneous abortion, which was of 3 months amenorrhea at her residence. Patient gives history of bleeding per vaginum, but is unsure of the nature of products of conception. UPT was done by self at home at 2 months of amenorrhea. After 2 weeks, she visited a hospital for persistent bleed per vaginum, where UPT was done and was found positive, and she underwent an instrumental evacuation. Ultrasound and histopathology was not done. Following which, patient had persistent bleed per vagina intermittently, 3 to 4 days of flow with bleeding free intervals of around 5 to 7 days, and changes around 1 pad per day, which is not associated with any passage of clots or pain in abdomen. She gives a history of undergoing curettage twice, and the sample was sent again for histopathology. The first report was unavailable, but the subsequent report it showed some pathology for which she was referred to our center. There is no history of any pain in abdomen, mass per abdomen, no history of discharge per vaginum or mass per vaginum. There is no history of any significant weight changes or any loss of appetite. No history of any other bleeding manifestation, jaundice, no history of any dyspnea, hemoptysis, cough, chest pain. There is no history of melena, no history of easy fatigability, no history of palpitations. There is no history of tremors, excessive sweating, or history of any headache, vomiting, seizures, or any visual disturbances. Patient has been investigated with, okay, this I'd like to skip because that will not be a part of your history ever. So the menstrual history of the patient. Age of menarche, 12 years. LMP, so-and-so date. Previous cycles were regular, 3 to 4 days of flow, 28 days cycle, using 22 days, 2 pads per day, not associated with any dysmenorrhea, clots, or any history of intermenstrual bleed before. Obstetric history, she's married for 5 years, P2, L2, A1. P1, first was a normal vaginal delivery of 4 years, girl child, alive and healthy. Second was again a normal full-term vaginal delivery of 2.5 years, boy, alive and healthy. And then was a spontaneous abortion at 3 months amenorrhea, period of gestation 6 months ago. And there is no contraceptive method which has been adopted by the couple. She is not sterilized as of now. Past history, there is no known history of diabetes, hypertension, thyroid, bleeding disorders, or seizures, or Cox disease, and any asthma. No history of any previous surgeries or blood transfusions or allergies. There is no history of molar pregnancy in the family or any history of bleeding disorder, diabetes. So that means family history is basically not significant. Personal history, she consumes a mixed diet. Appetite is normal, sleep pattern adequate, bowel bladder habits are now normal, and there's no history of any recreational drug abuse. General physical examination, patient is moderately built and nourished. She's conscious oriented, weight is 54 kgs, height 154, making her BMI 22.76 kgs per meter square. The pallor is present. No icterus, cyanosis, clubbing, lymphadenopathy, or edema is seen. Breast, thyroid, and spine are normal. Vitals, pulse is around 83 beats per minute, regular rate, rhythm, and volume character. Blood pressure is 130/90, right arm sitting position after 5 minutes of rest. Respiratory cycle is around 18 cycles per minute. CVS S1 S2 heard, that means systemic examination is mostly normal. Abdominal examination on inspection, normal in shape and contour. Umbilicus is central and inverted. No scars, sinuses, or dilated veins. Hernial orifices are intact. On palpation, there is no local rise of temperature or tenderness, and it corroborates with the findings on inspection. There is no palpable mass. The abdomen is soft. There is no organomegaly. On percussion, there is no free fluid. Auscultation, bowel sounds are heard. On local examination, external genitalia, urethral opening, and paraurethral region appears normal. On per speculum examination, vagina looks normal, cervix is directed backwards, downwards, appears normal, and there is minimal bleeding through the os present. On bimanual examination, uterus around 12 weeks size and mobile. Bilateral fornices are free and non-tender. On per PR, rectal vaginal mucosa is free. So my case summary happens to be a 23-year-old para 2 L2A1 with complaints of spontaneous abortion at 3 months of amenorrhea 6 months ago, followed by persistent bleeding per vagina, for which you underwent curettage and histopathology reported as malignancy, and finally was referred here for further investigations. There's no clinical feature suggestive of any mets or thyrotoxicosis, and that's about it.